Hi, everyone. Thank you so much for joining us today for today's discussion on common billing mistakes. The only constant in healthcare, as we all know, is change. So just a little disclaimer that the information we're sharing today is effective and relevant in today's date. However, please be mindful that information is constantly changing and we should all keep up with those changes. About us, I'm Alicia Shickle. I'm president of Garfunkel Health Advisors. I have over 36 years in the industry, both in clinical and administrative areas. Currently, we do a lot of work, documentation and coding compliance, revenue cycle integrity. We do a lot of work with the law firms on overpayment recovery and risk mitigation. So today we are really excited to share some of our experience with you on some of these common billing mistakes. I also want to introduce you to Simon Chaykler. He is a new associate with GHA. He's been with us almost a year now. He has extensive experience in healthcare administrative operations. He's very, very strong background in revenue cycle integrity, documentation and coding, payer policies. He is also a certified professional coder and medical auditor. Okay, today's objective. We want to talk to you today about the revenue cycle, as we're going to talk through some common billing mistakes. Overall, the billing mistakes are components, and as you'll see, different components of the revenue cycle. We talk a lot about documentation and coding, and that truly is a critical component of the revenue cycle, but it really is only one aspect. So we know how all the different building blocks of the revenue cycle really can make it complex. Payer policies, all the different areas, which we're going to take you through today. Again, the revenue cycle process begins when the patient or provider schedules the surgery, and it goes all the way through those processes until payment has been received and those accounts are reconciled out. So today we're going to take you through some common pitfalls and give you some solutions to achieving a high performance revenue cycle in your centers. Okay, so here are the some common billing areas where we see some common billing areas in the revenue cycle. Incomplete patient information or demographics. We see a lot of issues where we have missing prior authorizations, inaccurate, incomplete, missing operative report information. We're going to take you through some details there, what's required, where we see some issues, and hopefully how you can give you some help internally. Medical coding and billing, we'll look at some of those, and then we're going to talk about some modifiers, specifically modifiers 52 and 53 today. Okay, Simon, you want to take us away in some of the details?
Great. Incomplete patient information and/or demographics. We know that the medical record keeping is a vital element in providing the care that the patient needs. As a result, it is extremely important to always have a complete and accurate medical record, not only for record keeping, but for billing purposes. One of the most common triggers for denial of a claim is inputting the wrong information or accidentally leaving a claim field blank. So the medical record begins with the front end staff gathering as much of patient demographics, financial information, and social economic information as possible prior to the date of the surgery. This process not only helps ensure that all patient information is gathered, but also a clean claim can be produced. Patient demographics often includes information such as the name, address, and phone number and email of the patient, the date of birth, primary and secondary insurance information, whom the policyholder is, the reason for today's surgery, the referral and referring physician, any prior test results, authorization, the diagnosis and CPT codes, and consent forms such as your HIPAA, assignment for benefits, notice of privacy, and so on. So the primary duty of front-end personnel is to act as a liaison between the physician and the patient. In doing so, it is important to ensure that your staff has the proper tools, training, and education in the collection of patient demographics and insurance verification. By ensuring that the patient's insurance is verified, prior authorization is obtained, and all patient demographics is collected, there will be a higher chance that the claim will have a first pass rate. And we all know that everyone wants a first pass rate for claims. So some of the advantages of having trained staff is that the staff is aware of what is required and needed of them. Insurance benefits could be verified for coverage, copays, and deductible. Patients are aware of what is needed at the time of the service. And the back-end staff has all the information available for proper billing. On the other hand, when front-end does not have enough training, it may result in insurance carrier rejecting a claim when it is missing key data needed for an official determination of the claim. Old insurance card and ID cards are submitted on the claim form and is not recognized by the insurance carrier to which the claim is submitted for. And errors in patient information are made when staff manually enters it into the system, such as transposing numbers and letters in the insurance card, date of birth, and or zip code. When patient information is incorrect or missing, the billing can be delayed. The practice may see an increase in accounts receivables or a total denial of the claim. So it is best to have all patient information accurate prior to the claim going out the door to the insurance carrier. Prior authorization is another key component in avoiding claim denials. Although prior authorization creates an administrative burden on healthcare practices, it has now become part of the new norm. Prior authorizations is defined as obtaining authorization from the insurance carrier prior to the date of service, allowing medical treatment due to the patient's medical need for it. So it is the front end's responsibility to ensure that every single patient is checked for patient eligibility and insurance coverage, and obtaining prior authorization for surgical procedures prior to the date of the surgery. So what are the causes of not obtaining prior authorization? Not obtaining prior authorization may be caused by lack of staff training. The EMR does not have the compatibility to verify and see if authorization is required. Poor physician requests such as missing CPT codes and diagnosis codes. Again, it is the provider's responsibility to state upfront what the planned procedure being performed is and what is the need for it. Having a decentralized system and not having a structured pre-registration team. The effects of not obtaining one prior to the date of service could lead to claim denial, the need for appeal of the claim, loss of revenue or decrease in cash flow, and increased staff work for accounts receivables.
I know one thing, Simon, I just want to chime in. We also we have a registered health information administrator, and GHA performs a lot of chart reviews for medical record compliance purposes. And we see that a lot with our clients where they have decentralized systems, multiple systems. Again, that increases your chance for error when there's a lack of communication between those systems, specifically for those, this authorization and those demographic purposes.
The key to a successful revenue cycle is to ensure that patient is pre-registered within 24 hours of their scheduled procedures and that their insurance verification is taken care of. It is important to review all payer policies for all the services rendered at an ASC to see if authorization is required. Although most outpatient surgeries require one to be obtained, each payer will have slightly different rules governing covered services. So it is also important to update quarterly your EMR systems with the policies and procedures of all acceptable insurance payers. Also keep track of different reports and run them periodically to identify the problems that exist for each payer and to educate the front end staff on how to reduce prior authorization denials. The easier the issue is to detect, the faster a compliance plan could be implemented, the faster the practice will see results.
Great. So everyone that knows me knows that this is a very big area where I tend to get up on my soapbox. When we talk about inaccurate, incomplete, missing operative report information as part of common billing errors in the ASC, again, the documentation is critical. The operative report is the #1 important document that really houses all the details of the surgical procedure, describes each part of the surgery. And it really is your medical, it's the key to your medical necessity. So Simon, do you want to take us through the different components of the op report, what's required in each of those?
Yeah. So let's go over what is required in the operative report. The operative report is broken down into 4 different parts. The heading, which is the introduction, the indication for the surgery, the body, and then the findings and follow-up. So the heading typically includes patient information, the date of service, the facility or ASC information, the surgeons, the preoperative and postoperative diagnosis, and the procedure that is being performed. The indication for the surgery provides more of a medical background on the patient. So what is the patient's past medical history? What is the reason that the patient is having the surgery? Any family history, other pertinent information, and the illness or injury that has occurred if it's applicable. The body of the surgery is where your meat and potatoes are. It is the description of the procedure, which typically starts with the provider prepping the patient, doing the intraoperative report and its findings, removing any specimens or inserting implementations, the approach of which the surgery is, laparoscopic, is it open approach, and then wrapping it up with the closure. If multiple surgeons are present, then each surgeon is required to have their own unique operative report detailing what their unique portion was. And finally, the findings and follow-up includes a summary of the findings, any complications that existed during the surgery, and follow-up treatment. So we always say if it is not documented, the insurance carrier considers the service as not being performed. So it is important to have the key elements documented within the operative report. So what are the effects of not having an operative report or poor documentation? The provider and the ASC will see an increase in AR days, charges are being posted after the bill has been already generated, the surgical procedure might possibly be unbillable, or the provider would have to be queried for additional clarification and changes supposed to be made to the operative report, and increased financial risks and accounts write-off. As a result, each policy must establish internal policies and procedures to address key areas such as the timely completion of medical record, ensuring that no charges are being posted after a lag time, the coders and billers follow a QA process to ensure that all the components are complete and accurate prior to generating the claim. The providers are educated, especially those that are outliers, and ensuring adequate staffing guidelines and procedures for everyone, whether it's front end, the clinical staff, or the back end.
And one thing I want to add here, I know you're going to take us through like a checklist we put together, but it's really critical to be aware of the medical documentation, the documentation requirements for the services, specific procedures and services that you are providing, because each one of those within themselves may have very specific criteria. If the documentation doesn't contain accurate, complete, comprehensive, detailed information, then the back-end staff, the billers and the coders are not going to have enough of what they need to actually select accurate codes for reimbursement. So if there's a disconnect there, that may also cause different types of issues on the back end and the billing. So understanding if you need to document things like depth and the number of lesions and, your approach, all of those things are critical to selecting the correct codes.
So here we put together a checklist of all the components required to be present in the medical record in the event that an insurance carrier will audit the encounter or just for legal purposes. So this is not a comprehensive list, but rather a guide of the critical information that is typically found in an operative report. For example, the operative report must include the date of service, pre and post-op diagnosis, procedure name, findings, and so on. And it is the providers and the ASC's facilities' responsibility to ensure that operative reports are timely, complete, and accurate prior to submitting the claim to the insurance carrier.
So we wanted to just take you through some, this slide really pertains to coding and billing common errors. And the revenue on these types of errors can really vary from small amounts to very large amounts. You may be losing out on revenue, or you may ultimately be putting yourself at risk for having to pay revenue back. So a few of the common coding and billing errors we just really wanted to make you aware of is that being careful for unbundling, right? If there's one code that best describes the procedure or services that you're rendering, then don't unbundle those into multiple codes, because that can impact reimbursement. Be aware of under and over coding. That's really critical. It impacts payment integrity. Again, making sure that you understand what modifiers are applicable to you, capturing all the supplies that you should, making sure your diagnosis codes are to the highest level specificity, being aware and mindful that, have processes in place that you're not submitting duplicate claims or getting close to exceeding or missing out on timely filing. So all of these are, billing errors that can occur. So this is some data, which is really interesting, just to kind of give you a little overview. We took this from the National Improper Payments, from the 2021 data, improper payment error rate from the CERT reviews. And if you look at the pie chart here, look at the percentage of improper payments are based on 64% based on insufficient documentation under audit. over 13.5% of the claims were denied for medical necessity. You can see 10.6% of all the errors were due to incorrect coding. And then there was some other, issues, or they just never received the documentation. But look at that, 64% of denials were based on improper or insufficient documentation. So it's really important to make sure that you're running constant reports to keep track of all of the components of the revenue cycle, right? What's happening at the front desk. If you're seeing issues where you're getting denied for demographic or lack of prior authorization, do a root cause analysis of where your denial is coming from, and then go to those specific areas and provide additional education and controls to mitigate those risks going forward. Having a really strong QA process, making sure that the claims are going out clean, tracking all non-covered services, and then really important to follow up, track any coding and billing denials and follow up on those. We know in our organizations, that's one area where we really don't put enough resources. So keeping track of everything and then following up is going to be critical. Okay, Simon.
So one thing I want to add here is that most insurance carriers have a very strong scrubbers that incorporate all policies and procedures such as NCCI, mutually unlikely edits, medical necessity, and will likely reject the claim right away if there's some type of error that is detected by the system. So it's important to know all these resources upfront. So some of the resources that coders and billers should be using are national correct coding initiatives, which are used to promote correct coding initiatives on 2 or more procedures that are being performed on the same day. Your mutually unlikely edits, your NCD and LCDs, which are national policies, national and local policies for the medical necessity of procedures. And it's always important, again, to educate and to train staff, ensure that all coders and billers undergo webinars, they do their research from medical societies, and they keep up to date on major changes. We know CPT codes change annually on January 1st of every year, and ICD-10 CM diagnosis codes change October 1st. So a couple weeks ago, we saw new ICD-10 diagnosis codes were released, certain ones were deleted, and others had more specificity to them.
There are actually quite a few changes this year. So, just kind of echoing off of what Simon's saying, it's a really good time now. Get in there and see if any of those things are applicable to the services that you render.
So another common billing mistakes made are with modifiers. A modifier exists to help communicate additional information about the treatment or condition that a procedure code otherwise does not. Unfortunately, modifier errors sometimes occur when modifiers are misused to seek payment. This results in unclear reporting or oversight of the codes, leading to enhancement in denials. The higher the mistake in the usage of the modifiers, the greater chance that the claim will be denied or audited. Depending on whom the claim is submitted for, either professional claims by providers on a CMS 1500 or ASC facility billed on a UB04, each have slightly different modifiers for reduced and discontinued procedures. So for professional claims, there are 3 circumstances in which a provider may choose to reduce or discontinue a procedure. This includes completely terminating the surgical procedure prior to the start of it, reducing the service midway through the surgery due to unusual circumstances, or the discontinuation of a surgical or diagnostic procedure after the start of it. On the other hand, for facility billing, there are only 2 scenarios. A procedure can either be discontinued prior to the start of the anesthesia or after the start of the anesthesia. So understanding if anesthesia was administered or not will be crucial to understanding how billing works for the facility side. So for today's presentation, we'll only be going over the billing scenarios and modifiers. So the termination of surgical or diagnostic procedure prior to the start of the service. There may be times when a patient presents for surgery, and while the patient is being prepped, the patient's blood pressure becomes uncontrolled, right? Due to uncontrolled blood pressure, the surgeon may make the decision to cancel the surgery due to the poor management and then just reschedule it for a later date. In that case, the surgeon is unable to do any billing for the surgical procedure because of the underlying condition, right? And since the surgery was not performed, we can't do billing for the surgery. So the healthcare professional may, in some cases, bill the evaluation and management codes for the time spent managing the patient's blood pressure and bringing it under control. So the reason being in this case, since the surgery has not been started and anesthesia has not been administered, there's no surgical procedure billing. Again, documentation should be present stating that the surgery was canceled due to patient's medical condition or conditions, and state what those conditions are and how it affected the provider's decision. Modifier 52. What is Modifier 52? Modifier 52 identifies the service or procedure that has been partially reduced or eliminated at the provider's discretion. This service is described but not always completed to the full aspect of the CPT description. So it is appropriate to use modifier 52 when the provider midway stop the surgery due to unusual circumstances. And again, as always, documentation must be present, and at a minimum, the operative report must state what the service was, ensure that no other CPT code descriptor fits the scenario, and what portion of the procedure was not completed and why. So was the procedure not completed due to difficulties in the area or due to an absence of a patient organ, for example? And finally, 53, discontinued the surgical or diagnostic procedure after the start. Modifier 53 is defined due to certain circumstances where the physician or other qualified healthcare professional elects to terminate the surgical procedure due to excruciating circumstances and in which the life, the patient's health is put at risk. So for example, during the surgery, patient's blood pressure went up to 200/10, causing a life-threatening situation. In that case, the provider will was only able to perform part of the surgery. So note that if multiple procedures are planned, you can only build the most comprehensive procedure with modifier 53. As always, supporting documentation should state that the procedure was started, why the procedure was discontinued, and what percentage of the procedure was performed. So the end goal for practices is always to reduce the amount of mistakes that are made. Through audits, we continue to see the same thing over and over again that causes rejections and denials. Some of the common mistakes are missing modifier on the claim form. Again, are the coders and billers reviewing the documentation? Who's responsible for adding the modifiers? Incomplete operative report, for example, does not state why the procedure was reduced or discontinued. Who is reviewing the documentation prior to the submission? Are the providers aware of what they should be documenting? Missing information in the narrative of the claim form to support the use of the modifiers. Facility only claims used on professional claims. Are the coders and billers choosing the right modifiers? If your practice is adding the wrong modifiers, how do you avoid that? And finally, applying modifiers to non-surgical procedures. We continue to see the same issue over and over again. For example, modifier 25 added to surgical procedure, which gives the insurance carriers a picture that the practice does not know what they are doing. So if you're applying the wrong modifiers, most likely the claim will be rejected right away. So knowing your practice's common mistakes will allow you to make changes that are specific to your practice.
Definitely. Awesome. So I think we're about at time here, but we really just wanted to take you through our final recommendations and some takeaways, hopefully that you'll be able to bring back and incorporate into your practices and centers. establishing those internal policies are really going to be critical. Clear, strong policies are going to be your outline for communication across the board with all of your staff, right? And then also accountability is a big deal internally. So you want to communicate what your processes are, what your expectations are, and make sure everybody is aware of that. Another great control internally to help mitigate some of these issues and avoid problems is educate, right? You have to educate and train your staff. It's okay to give them policies, but unless they really understand what that means, it's probably not going to be very helpful. So educating everyone from the front end staff, which is the beginning of the revenue cycle, all the way through what's the expectation and required of the providers, the clinical staff, and then on the back end, the billing side, making sure everybody understands what they need to do. And then having all of those controls and processes in place, you're not really going to know if they're effective unless you take the time to monitor on a regular basis what's happening, and then audit. You really need to audit all of the components of the revenue cycle. When we think of auditing, we think of provider auditing, but you should be doing, random audits of, hey, how well are we doing at the front end? Are we capturing everything correctly? Are we paying attention to detail? And then, of course, auditing on the clinical side to make sure that the documentation is there to support medical necessity and the services that you're billing for. And then on the back end, spot check to make sure, are all the processes of the claim submission happening, accurately? Are you following up on those? What's happening with denials? Are we hitting timely limit filing limits? Because that's a big issue. And then you can always implement modifying factors there to avoid those types of issues. And then again, keeping up with the industry changes, right? We talked about that in the beginning. CMS, the AMA, we have the new, Simon told us about, the new codes that come out in October and January. And then not just the codes, but payment policies. It's really critical. Even if you're getting the coding right, you still have to add that additional layer of the payment policies and payment requirements. And then benchmarking, right? Keep track of what's happening. Get to the root cause of issues, implementing corrective action, and just continue to provide education, update your policies. Keep doing those audits. We know someone who can help you with those, wink, wink. But yeah, I mean, it's critical just to test to make sure that your internal controls are effective and working. I think we're going to move now. So here's some resources. I know you'll be getting a copy of the presentation of where we got a lot of our information from today. So it will be helpful for you. And I think we're going to move now into the phase of taking some questions. So thank you so much for participating today. We hope this was helpful, that you'll have some real tangible takeaways for today to help your practices improve and mitigate your common billing mistakes. Thank you so much.
Thank you.